Hi everyone, my name is Aaron Seiler. I'm the new obstetric anesthesia fellow over at the University of Chicago, and I've been asked to make a presentation regarding whether or not we preload IV fluids prior to placing an epidural catheter. And it seems like there is some question as to previously we would do a preload, now we don't do a preload, some people do, some people don't. What's going on with all of that? And whenever there is a lack of consistency, it can be confusing. So my goal is to try to explain some of the background information and the rationale that we use for why we do or do not preload IV fluids prior to placing an epidural. So just a couple of quick things to make here. This presentation is in the context of generally healthy routine labor epidural placement. There are always going to be certain pathologic processes that may deviate from the plan. There may be other outstanding situations. Also, this doesn't necessarily apply to spinals or when we are dosing for a cesarean section, but this is just for a generally routine labor epidural in a generally healthy patient. And we tried to cover the T10 to L1 or 2 nerve roots for the uterus for the early stages of labor, and then the lower sacral nerves S2 through 4 for the later stages of labor to cover the perineum. Many clinicians today will use about 10 milliliters of 0.125% bupivacaine. So that bolus will come out to about 12.5 milligrams of bupivacaine. Some may do a little bit less. And then what we expect to see physiologically as a response to this is vasodilation, mostly in the lower extremities. That will cause a decrease in preload, so less blood is returning to the heart. When that happens, there is less blood for the heart to pump out, so the afterload or blood pressure will come down. And then on occasion, you may see a decrease in the heart rate, although that's not always the case. So, in the beginning, part of what started this whole process of bolusing IV fluids prior to placing an epidural was this study from 1978 done by Collins. And what he did was he took two groups of patients, and half of them got a liter of fluid before placing an epidural, and the other half did not. And he found there was some significant change or differences in the rates of hypotension and also in the rates of fetal heart rate tracing abnormalities. And so the patients who did get bolused with a liter of fluid, they only had a 2% rate of hypotension, whereas those without the preload, it was about 28%. So that's a pretty significant difference. And then there was also a big difference, as you can see here, in the numbers of people who had changes in their fetal heart rate tracings. But one of the big differences between that study and today is that at the time they used 10 milliliters of 0.375% bupivacaine, which comes out to about 37.5 milligrams of bupivacaine, which is much, much more than what we often use today. And this larger dose of local anesthetic is the reason why these patients had such dramatic changes in their blood pressure. Also of note that in this study, while recording the blood pressures, he would have the patients lying supine, and we know that that position can have dramatic effects on the blood pressure because of the uterus compressing the vena cava. So then fast forward a couple of decades, and people started trending towards less and less concentrated local anesthetic. And then people were wondering, since we are using lower concentrations of local anesthetic and giving people less bupivacaine, do we still need to bolus them with fluids prior to placing an epidural catheter? And so the study in 2000 by Kinsella, they had two groups of patients. One got a liter of fluid, much like the study back in 1978. The other got no preload. And then when they dosed the epidural, they only used 15 milliliters of 0.1 or 0.2% bupivacaine with a little bit of fentanyl. And they noticed that there was no significant difference between the two groups in regards to their changes in blood pressure or their changes in fetal heart rate. And their argument was that because they are using less local anesthetic, that the effects of the local anesthetics on blood pressure was less dramatic, and so the fluid bolus that patients got did not make any significant difference. So a year later, Hawthorne did a similar study, and they did a no preload group and then a group that got 7 milliliters per kilogram, which comes out to about half a liter, maybe 600 mLs for the patient. Those patients were bolused with 20 milliliters of 0.1% bupivacaine with a little bit of fentanyl. And that study found that there was no statistically significant difference in the blood pressure between the two groups. And then in 2003, a third study that looked at changes in blood pressure and also changes in fetal heart rate. Those patients got a similar bolus of around 500 to 600 milliliters versus no bolus. And the epidural was 15 milliliters of 0.1% bupivacaine with a little bit of fentanyl. And all of these studies showed that whether or not a patient got a preload of fluid, it didn't really make a difference between the way that their blood pressures behaved or their fetal heart rate tracings. And the argument is that these patients in these more modern studies all got around 15 to 20 or so milligrams of bupivacaine, whereas in the earlier study from 1978, those patients got 37.5 milligrams of bupivacaine. And it's that difference in the dose of the local anesthetic that is responsible for the changes in their results regarding blood pressures and fetal heart rate. And so what you can see here are two of the graphs from the 2001-2003 study. On the y-axis of both of these graphs is the blood pressure, and on the x-axis is time, starting from when they first dose the epidural catheter. And what you can see is in both studies, both groups, the preload and the non-preload groups, did have a small drop in their blood pressure. And that happens to everyone, at which we expect after bolusing an epidural catheter. But what you can notice is that the curves for the preload group and the non-preload group are almost identical. They almost entirely overlap. And so it's not saying that patients will not get a drop in blood pressure from an epidural. Many patients will get a drop in blood pressure from an epidural, and some patients may get a minor drop. Some people may get a more significant drop. But what the study is showing is that it doesn't matter whether or not you get a fluid preload bolus before the epidural. It'll behave similarly regardless. And here is from the 2003 study. They not only looked at blood pressure, but they also looked at the fetal heart rates. And this is all of their information in table form. And so here, this is the number of people that had a significant drop in their blood pressure. And like I said, there will be some people who have mild drops in blood pressure. There'll be some people who have more significant drops in the blood pressure. But what this shows is that if you got a preload, or if you didn't get a preload, it's about 11 to 13% chance of a drop in blood pressure. And on the far right side, you see the p-value, which shows that at 0.6, it was not significantly different from a statistical standpoint. And so there's, in a kind of a gross overstatement, you can say that there's no difference there. This is looking at the maximum drop in blood pressure. And again, people's blood pressures will drop, but between the no preload group and the preload group, it didn't seem to make any difference. And then here is when they're looking at the fetal heart rate changes. And again, it's, in the preload group, it's 14.5% of them. In the no preload group, it's almost 20%. But ultimately, from a statistics standpoint, there wasn't any significant difference between the two. And so now you may be wondering, well, okay, you just said everyone who gets an epidural bolus will have some degree of hypotension, and a fair number of them will have some change in the fetal heart rate tracing. So why don't we just bolus everyone then, since we know that there will be a degree of hypotension in those patients? And so the reason is because there is no shown benefit from doing it, but there is, however, some degree of harm potentially from doing this. And that harm can be very mild. It could just be that a patient who is in pain and is requesting an epidural now has to wait for that bolus to go in, and then you can set everything up and give them the labor analgesia that they are requesting. That harm can be more significant, though, in certain disease states, such as heart disease or preeclampsia. That fluid overload could be problematic in preeclamptic patients. They can get some pulmonary edema. And then additionally, patients with significant kidney disease are in a very tenuous state regarding their fluid balance. And so we don't want to just give fluid um, if it's not going to help them. Additionally, there has been some data out there that shows that fluid boluses can temporarily decrease uterine activity, which can have some effects on the labor process in general. And so, like I said, this is intended as a general guidance for routine labor epidurals in normally healthy or healthy-ish patients. There will always be clinical situations that make us deviate from this, um, such as severe hypovolemia. Those patients may need to be given fluid so that they are at a more balanced fluid state before doing this. Um, Also, this is for labor analgesia. This is not intended for when we are dosing medication to get ready for an operation like a cesarean delivery. And when in the operating room doing a spinal for a cesarean delivery, the anesthesiologist should be administering an IV co-load, which basically means the IV fluids are going at the same time that we are placing the spinal, as opposed to a preload where we get it all in beforehand. But that is something for the anesthesiologist in the operating room to be in charge of. Thank you.